sentiment.
In your lecture, you had only a few number of patients who were operated 2 days after. When you had patients who were operated on the first day, what can you give the percentage of perforative versus non-perforative?
I can't remember the exact percentage, but I see the point of your question. Now, okay, tell you that even those who were operated on the third day, there was no significant increase in the morbidity. That's when you hear that there were some patients who were operated on the third day that were observed for 3 days. Okay. Actually, there's an implication that they were diagnosed late, okay, and there might be some perforation, and therefore this might lead to an increased incidence of morbidity. Okay. Now, just to tell you that, just try to recall the natural, let's call it the natural history or the course of the disease of acute appendicitis. In the early stage of acute appendicitis, practically the signs are minimal or even negligible. They are very vague. Okay. Now, if you let time pass by, then if that acute appendicitis will progress, then you'll get more signs and symptoms which will be more evident to the clinician. Okay? So it is usually during the time that the patient has the suppurative acute appendicitis, the diagnosis is quite easy. Okay? Because you have a definite right lower quadrant localized tenderness. Okay? Now, in the early stage, probably you can get only mild tenderness, which will not convince you that the patient will have acute appendicitis. Now, those who are diagnosed on the first day, majority, the great bulk of the patients were diagnosed on the first day. And this consists of those who presented with frank obvious signs of peritoneal irritation. Okay? Now, those who were diagnosed on the second day, the third day, okay, most of these patients, if I remember right, when they came in during the first day, okay, of consultation, their presentation was quite equivocal. The findings were equivocal. Okay, so these patients presented with early acute appendicitis. Okay, so we followed these patients for the next 2 days, for those who were operated on the third day. And then the third day, the signs were quite evident already. Okay? So we did have a patient, I did, because these were patients whom I saw personally. I did have a patient who were observed until the time that the appendix perforated and lead to generalized peritonitis.
No mention was made during the time of observation. You said there were some patients who were operated on the second, and the third, and the fourth day. During the time of observation, were they undergoing any medication?
No, no medication at all. They were just purely palpation, asking the patient, is the pain increasing, the same? Okay. And the palpation, if there's a definite tenderness or more tenderness, no medication at all. There were some patients that I even asked them to eat. While observing. No medication, but even no antibiotics, no analgesics. I just advised the patient that we're trying to roll out acute appendicitis.
I think
doing this observation in adults will be a little easy. But when confronted with patients who are very young and very apprehensive and readable individuals, it will be a little difficult. How would you elicit peritoneal irritation and exhibit right iliac tenderness and muscle guarding in a very young individual?
The same procedure that you would do for adult. Now you just keep on going back to the patient, palpate the abdomen. So in such patient, young patients, most of the time it's hard to communicate. Okay, you will get unreliable answer. So we rely on your physical finding. Okay, as I know, it's true that pediatric patients are difficult to evaluate when it comes to the abdomen. Okay? So you just have to be patient. Go back to the patient every now and then until you are quite confident that you are dealing with that there are signs of peritoneal irritation.
Have you made any comparison with in relation to your accuracy in diagnosis in the very young and the adult individual? Do you have more or less the same success in making a definitive diagnosis of acute appendicitis in different stages?
Yes. We follow these patients up. And usually when you look at appendicitis, it's around the age of 7, 6, 7. Even a little younger than that, probably, no? The patients will be younger.
You encounter more ruptured conditions in the young than in the adult in the process of observation.
In the process of observation, there was no increase in the incidence of perforation. There are some patients who, especially those, in fact, there are perforations during the first day. Because this patient presented already with frank signs of peritoneal irritation. Some of them have been observed at home without the guidance, supervision of the doctor. So when they presented to me during the first day, that's the reason why great percentage were diagnosed during the first day, because they presented with frank signs of peritoneal irritation. Does that answer your question?
Suppose you are confronted with a patient about 5 or 6 years old or younger, whose abdominal pain has existed for about 4 or 5 days, and then on examination you see with a vague large mass of the right lower quadrant. Then the patient is looking into toxic. Would you decide to open?
If the impression is appendiceal abscess. Yes.
Would you not observe and make some medical treatment first before opening?
Okay. My stance that for appendiceal abscess, I don't do conservative management. There are two schools of thought before for appendiceal abscesses. One is early surgery, the other one is conservative management. Okay. In 1970, I came out with a paper that it's more cost-effective to operate on patients with appendiceal abscess as early as possible. There are more benefits that you can get from an early surgery. Okay. One, you drain out the abscess. Two, you remove the source of infection, which is the appendicitis. Okay. Three, you save the patient one additional operation. One additional hospitalization. You save the patient from 2 courses of antibiotics. So I said, probably at this point in time, I would like to impart this teaching if you have patients with appendiceal abscess, operate. Because as part of my lecture, when you have abscess, you operate. One exception probably when you're dealing with abscess of the liver, which can be treated medically. But for other forms, other kinds of abscess, the rule is you drain that abscess.
I have a question with that. Suppose you have more or less the same situation, and the condition has existed for about more than 1 week. And on history, you found out that the mass has been receding a little. Would you still decide to open and drain?
Okay, it depends on your clinical impression or suspicion. If you strongly consider appendiceal abscess, you go ahead. But if you think it's something else, it might be something else, let's say elective or abdominal conditions, which can be treated on an elective basis. Okay, that's an abdominal hydrocecal mass. Okay, then you can proceed with your laboratory investigation.
What I mean here is you are sure that it's already very appendiceal abscess. And on history, you gathered that this patient, when you saw him for the first time, the mass has receded a little.
Okay.
It has receded. In other words, there is already a resolution. Would you still open and drain? That's the question. There is certitude in the diagnosis of periappendiceal abscess.